All right, thank you. All right, we can get started. So I'll mostly be talking about this one particular intervention and two studies associated with that. But I'll also have a bonus round at the end where I'll just go through the different studies we're doing in case people have other interests as well. It's not advancing. Oh, it is. Okay, I see.
Sorry.
That's okay. Did that work? Okay. All right. So that is so this is my acknowledgement slide. So the nonprofit Possible on the top left is it's a nonprofit that I co-founded many years ago with my friends, and it does sort of a mix of service delivery and intervention research. Top right, UCSF is where I'm based. Bottom left, ODIC is a community-based organization in Nepal. And they've been working in women's rehabilitation and reducing domestic violence for about 30 years. The two pilot studies that I'll be talking about today are funded by an anonymous donor and also by SVRI, whom I think people know about. And then that intervention is now being tested in an RCT that is funded by an NIMH R01.
Sorry, it's on that here.
So if I go forward, oh, there you go. Okay, all right. We'll figure it out.
Sorry.
That's okay. So intimate partner violence is a worldwide sort of problem, right? So if you look at national and international figures, 1 in 3 women report some kind of violence from their intimate partner. And these numbers, as you can imagine, sort of get worse as you get to regions where women have fewer educational and economic opportunities. And there are parts of Nepal where, women tell me, community health workers and so on, they tell me, oh yeah, the rates are pretty much like almost close to 100% if you include things like psychological violence, sexual violence, and physical violence. So what's being done about this sort of worldwide problem? At the first level, I would say, at the community and sort of societal level, there is criminalization. So this poster on the left that sort of says, violence is a crime. It cites the specific act that is being violated when someone, uses violence. And then it says, you can call these numbers and so on. On the right is sort of this awareness raising poster that talks about different examples of, violence and discrimination against women. So that's like the first category, right? So societal level, criminalization, and awareness raising. And then you have the second level, which is focusing on the individual experiencing violence. So the poster on the right is sort of encouraging the person to speak out and really, leave. So it sort of, has images of different ways women are discriminated against, and at the bottom, and the words say, how long is this going to continue for? And at the bottom it says, as long as you keep tolerating it. And I know what they're trying to say, but I'm a little bit worried about this kind of language. It's sort of like puts the onus on the woman who's experiencing violence to kind of fix their situation. But I understand where they're coming from. It's sort of like trying to convey the message that, hey, like this is not right. You should not just tolerate that. And then on the right is these sort of one-stop crisis management centers, or you can find them all over the world, usually embedded within an emergency department. And the idea is if you're in a crisis, you can go and sort of access multiple services, right? So you can access emergency services if you got injuries, you can get access to a counselor, you can even get access to a shelter, legal support, and so on. And it's just like trying to simplify the process for women who want to exit abusive relationships. So this is the individual focused sort of intervention. So where does that leave us, right? So if you think about these issues, not just as like, specific to an individual, if you think about the multiple levels of both drivers and intervention, I would say that what's happening right now is showing sort of two major gaps, right? So one is there's a community level intervention, criminalization and awareness raising, and the individual level intervention. But a lot of familial and some like interpersonal levels are missing in most of the interventions we have for IPV, right? So that's the first gap. And the second gap, when you do come to this individual level intervention, is that most of the interventions are around getting the woman to leave, right? And after you leave, here's a bunch of services you're going to get, right? So shelter. And again, all those should be there. I'm not saying they shouldn't be there, right? But what that leaves a lot of women in these very impossible situations, right? So you either leave the person and then face sort of, the society might abandon you, your own parents won't take you back. How are you going to take care of your kids? How are you going to take care of yourself, right? That's one path. The other path is you just tolerate violence, right? And we came to it from our work in mental health, in depression. I'd keep getting told, I was getting told by our counselor that, oh, there are these women with treatment-resistant depression. And every time, I try to meet with them, do a home visit, there was violence at home, right? So a high dose of antidepressant is not going to do anything if there's ongoing violence happening every night. So we're like, okay, what can we offer for these women? And then, of course, we'd say, can you exit? And they'd be like, no, like it's like social death if I separate and I can't, I never went to school, I can't take care of myself. Like, how am I going to do all of this? So there was this huge category of women for whom leaving was not feasible. And we really had nothing to offer for them other than saying, you should leave. You should leave. You should leave. And they were kind of getting annoyed. They're like, yeah, I've heard that, but I can't, right? So we're like, can we think creatively about this? What do we have to offer? All right. So that's the nature of the gap, right? So most of the stuff is community-based and individual-based. And even at the individual-based stuff, you have nothing to offer for women who are telling you that it's not feasible to leave. So based on these challenges, we sort of came up with this intervention. It's a mouthful. It's called MILAP, Multi-Component Family Intervention to Lower Depression and Address Intimate Partner Violence. And not a coincidence, of course, MILAP means sort of reunion or unification. And that's sort of the theme behind what we're trying to do here. So I'll walk through the components of the intervention. So at first, we actually have the mother-in-law and the daughter-in-law have sessions together. So why mother-in-law, right? So there are a few things. In Nepal and in many countries, when women get married, they move into their husband's home, and the mother-in-law and the father-in-law live in the same household. And what that means is the mother-in-law actually ends up being the default kind of manager for this young bride. And by manager, I mean someone who'll say, this is when you need to wake up. This is what's going to be made for dinner. This is who's coming. You can go to the market. All the do's and don'ts of like just running the household is actually under control of the mother-in-law. So that's something, we had seen, in our patients. That's something I had seen growing up in Nepal. My mom had moved in to my dad's home, and my grandmother, on my dad's side, would be the one who would sort of tell my mom what to do, what not to do. And so we'd seen that. And then the other thing that we had noticed was, because intimate partner violence was so common, we started doing what's called like positive deviance, right? So where is it not happening? And what's happening in those households? And oftentimes what I found was women would say, oh yeah, I get along really well with my mother-in-law. And sort of she's the one who looks out for me. I had friends be like, oh yeah, she loves making TikTok videos with me. Like that's how they would bond with like your mother-in-law. And she was like this mediator, right? And just like most social drivers of health, you can have sometimes even the same person be a driver of poor health. She could be the one instigating, saying, oh, he's not listening. Hey, like you got to set him straight, to her son, right? Saying, hey, like you got to like put this girl under control. Or at other times you'd be like, okay, hey, you better not do this to this girl. Like I'm going to look out for her. So it was this really interesting sort of power center. She's not the only person, just to be clear, but mother-in-laws ended up coming up over and over. So the mother-in-law and daughter-in-law sort of sessions include four things. And most of it's driven by motivational interviewing. A quick show of hands, how many people know what that is? Okay, about half, and I can't really do this on Zoom, but I'll just quickly explain what it is. So I'm like a motivational interviewing evangelist, so you should stop me if I talk too much about it. It's probably one of the most effective tools in the toolkit of like anyone who's in a helping profession, or anyone who has a teenager, really. So the idea is, how do you non-judgmentally listen to another person? You don't have to agree with the decisions they're making, right? And this is one of the biggest problems we have when you interact with people who have behaviors that we disagree with, right? It could be using drugs, it could be smoking, it could be alcohol, it could be not leaving an abusive relationship. Because we think, I would never do that. And because we think I would never do that, our advice is, you shouldn't do that either, right? But in motivation interviewing, the whole point is see the world from that person's perspective. Look at the choices that they're facing, right? And then only you can get to your what can I do for them part, right? So we take the same sort of stance with the mother-in-law, daughter-in-law interaction. So instead of saying, hey, you should really not do this or do that, we start by saying, mother-in-law, what do you care about from your household? And oftentimes it's stuff that we all want in our household, right? So kids are doing well in school, like things are safe, things are running well, like all the usual list. And then we say, okay, so now I get that this is what you want. Then you try to help her make the connection between how violence is actually, impeding the household reaching those goals, which is a better way to talk about violence than the usual sort of moral argument or rights-based argument, which again is good for the awareness sort of societal level interaction or intervention. But when you're talking to an individual, it's much more effective to say, here's what you want, and violence is actually keeping you from getting the thing that you want. And there's a bunch of other things as well. I'll point out behavioral activation, which is, it's one of those miracle treatments, really. It's like so low intensity. You can train someone with no mental health background on how to deliver behavioral activation, but the effect size on depression is quite high. And what it really means is when you're depressed, you get into this negative loop of feeling low, so you withdraw from things, you don't do things, and because you're not doing things, you feel worse, right? So you see that loop just getting worse and worse. Behavioral activation helps you do the opposite. You say, hey, I know you used to like, enjoying going to the market. Oh, and I know you have no interest because you're depressed. It may not be like 10 out of 10 fun, but maybe it'll be 5 out of 5 fun, or 5 out of 10 rather, 5 out of 10 fun. Let's see if we can make that happen. And the person goes and realizes it's actually better than they thought, and they get into this positive loop, right? So behavioral activation. Our counselors are doing behavioral activation with women, and they were so frustrated because the women don't listen to me. Well, what was happening was women don't have freedom of movement. So you set up all these activities, but she can't actually do any of them because she doesn't have the freedom to do any of those things. So we actually brought the mother-in-law as an ally to help the daughter-in-law engage in these activities. And that was the only way she'd be able to leave the house and do these other things. So after we do that for about 6 hours over 4 sessions, the second part is couples therapy. And I do want to mention that couples therapy for IPV is actually, there's a lot of literature for this. It's been around for decades. It's not as sort of available in practice, but the research world has actually done a really good job in testing couples therapy for intimate partner violence. And again, the goal isn't to go in and say, husband, all my work with IPV, I've never heard a person that sort of says, I am a perpetrator, right? So you go in with that language, they're not going to come in. And you want them to come in because they are actually the ones, conducting violence, right? So we say, okay, everyone's got relationship trouble. Everyone's got communication problems. Do you want to work on that? And people will say, yeah, like I got that. Like we all have that, right? So we bring husbands into the counseling sessions by saying it will help you with the communication skills, emotional regulation skills. And that's what the focus is on. And of course, in the process of doing that, we teach them de-escalation techniques. We teach them techniques on how to not let a small disagreement turn into violence and establish safety as well. And then there's a sort of triad session that just synthesizes all the information. So this is the intervention that we iterated over the multiple pilots. And I'll talk about sort of, what we have found so far around this. Yes.
So how willing are the male partners to come to therapy?
Yeah, and it's a huge problem, right? Because a lot of the times, they're like, well, I don't even see it's a problem. Like, why would, like, there's nothing wrong. Like, why would I even bother? And the mother-in-law in many cases actually is the one telling the son, you got to go into this therapy, right? And it's like this amazing power center because, like, again, it's not true for all sort of households, but like in these households that they were working in, and we saw that. And then the other technique we use is, again, not making it about violence, right? So saying, do you want to learn how to manage, the communication skills so that you can communicate clearly? Yeah, that's something people would agree to, and then bring them in that way, and then the sort of violence comes later around safety rather than starting with violence. It is still tricky, but yeah, so that's something to be mindful of when you're doing couples therapy. The other thing, of course, with couples therapy is you have to be very careful that violence is not worsening, because that is a known, potential adverse effect that you bring the couple in, and because of their interactions in session, there's actually the violence worsens at home. So, we have the counselors always check in separately to see if there's escalation of violence. We have separate research assistants that go in and check in to make sure there's no escalation of violence. So I don't want to make it seem like this is straightforward. So what does it look like under the hood? There's too many things here, so I'm going to try to point out just a few things. It is working. Okay, so as we said, so first we looked at what are some modifiable, that's a key term here, psychological factors. Because there are many, many things that can drive IPV, and we want to look at what can be modified, right? So these are some of the modifiable psychological factors we found in our qualitative studies. And then what are some interpersonal and family level drivers of intimate partner violence? And based on that, this intervention was developed with the same 4 components each that I described earlier, and a bunch of measures to look at whether each of these components is having any impact. And then the primary outcomes are, does it reduce depression, and also does it reduce IPV, secondarily looking at PTSD, and of course acknowledging that there's a lot of additional factors that we're not directly intervening on that do drive IPV and mental health. And what does it look like sort of in human form? So that's our counselor meeting with the mother-in-law, daughter-in-law, and the husband in the final session. And so I will talk about, I think there was another picture, but I guess not. Okay. So I'll talk about the 2 pilot studies where we iterated this intervention and sort of improved it through time. So both of them were sort of single arm, acceptability, feasibility, and safety interventions studies. And the first study was focused on a younger population. So women aged 15 to 24. And IRB, especially in the US, was like, what do you mean 15? These are like, child brides. And I told them the legal age of marriage in Nepal is 18 for the women. The median age of married women when they get married is also 18. Right, so half of the women are younger than 18. So we can turn a blind eye, or we can say, hey, this is what's happening. Let's bring them in, because they're actually very vulnerable. You can see like someone who's 15 or 16 getting married and moving into like a husband's home. They're very vulnerable to experiencing violence. So fortunately, the IRBs, after a lot of back and forth, were like, okay, we get it. And then after we did the first study, our partner wanted to expand it, because they were like, we see this working for older women too. So the second study was on reproductive age women. And the first one had 25 families, and the second one had 61 families. So the inclusion criteria, it's like you need to have had IPV, and you're not going to move out. You have mother-in-law living together, sort of the family structure we have in mind. And the main exclusion, we struggled with this, like how do you make sure that you're not bringing in women who are experiencing severe IPV. And again, you need this kind of gradation, because what we're offering is actually not appropriate when there's like this sociopathic level of violence, the kind of thing that you often hear in the news, like, dumping gasoline and lighting a person on fire. Couples therapy is not going to fix that, right? That person needs to go to jail, right? So how do we separate that out? And there are many different ways we thought about it. And what we ended up picking was, if there's been a hospitalization in the last year because of IPV, then we call that, if that's severe enough that the person not just went to the emergency room, but had to be hospitalized. So we use that as an exclusion criteria, but we didn't have any other exclusion criteria other than that. We're trying to make it as sort of real world as possible. And again, just to be clear, if during the course of their intervention or follow-up period, if we find out that there is severe IPV, we will, again, encourage heavily that they go and sort of, access these crisis management services. But again, you don't want to push people, because they're telling you over and over that it's not feasible for me to leave. Right. So the 2 sites, both of them were in southern part of Nepal, and our partner, the community-based organization, said that's where rates of IPV are the highest. And that's where, when you look at the indicators for women's literacy rates and economic freedom, they're the worst, and property ownership and all those are the worst. So that's where we're doing our studies. So this is our research assistant going around the neighborhood, just give you a sense of what life is like there, talking to a husband there, doing sort of the follow-up assessments to see how things are going. Quick on demographics. Let's see how we're doing on time. Okay. I'm going to run through this real quickly. So 21 was the median for the first study. That's with the younger people, 27 for the second. As you can see, in the first study, a quarter, the furthest they've gone is just 8th grade. And the second study, 46% have only gone to 8th grade. A vast majority of them, in terms of ethnicity, are sort of the most marginalized caste. And most of them were homemakers, again, reflecting lack of economic opportunities as well. So when you're a homemaker, if you leave the household, oftentimes, if you haven't gone to school, it becomes really difficult to make a living on your own.
Quick question.
Yes.
Of the husbands and the mother-in-laws.
Yeah. So the age differential for the men, I don't have it here, but like it was around sort of 4 years older than the women, and the mother-in-laws are young. And that's what you're getting at, right? So they're not that old either, right? Because most of them will have kids in their late teens and early 20s. So they were also quite young.
And then also similar education level. So everybody, this is
Yeah. Oftentimes, men have gone further in school than women, but mother-in-law, the literacy rates were much worse because a lot of these, education initiatives are more recent. All right, I'm going to show, the depression statistics, but again, pilot study, no control arm. All right, so let's not get too excited. That's why I got to tell my team over and over because these numbers are incredible. Right? So the first study, 46% of women had moderate to severe level of depression measured by PHQ-9. The intervention itself lasts around 3 months, and then it dropped to 4%. And we're like, redo the analysis because that's ridiculous. And they came back, they're like, no, that's what we're seeing. Again, let's not get too excited, but this is the kind of effect that you would see from like really high quality intervention. And the way just the second study, 67%, huge drops as well. We'll see what the randomized control trial shows, but the way I would try to make sense of this is it's, in mental health, we have this biopsychosocial framework, right? So they have these multiple, drivers that drive both health and illness. And we try our best to customize it, but often we don't. We may do a biopsychosocial assessment, but the treatments end up being, here's an antidepressant, here's a referral for therapy that you may or may not be able to afford. So what we're able to provide, I think, is a highly customized depression treatment where the social driver was clearly identified and the intervention matched that particular social driver. Because that's the only way I can explain this kind of huge reduction. But again, we'll see what the randomized controlled trial shows. Violence was a murkier picture. So this is in the last month, because we couldn't do last 6 months because then the intervention period will also be included. So this is data from any IPV in the last month. 30% on the first study said yes, 52% from the second study said yes. And it was going up and down, and it was very confusing. And we were like, if violence is going up, especially look at the first study, right? So it actually went up. So we sent the RAs and we, asked the, counselors, and we had a bunch of meetings. And then the woman kept telling us, no, violence has gone down. Things are better at home. And we're like, well, what's happening? Why are the numbers going up? And they were like, well, he was doing a lot of things that I did not realize were violent. And after, going through their intervention, they were like, oh yeah, that's actually abusive control. Like that's actually psychological violence. So the behaviors were getting better, but the reporting was going up because women were recognizing behaviors as being more abusive than previously thought. But again, we'll see what the larger study shows. I'm going to point out this one particular, we measured a whole bunch of things. And so this one, again, it's a busy slide, but let me orient you, right? So we're looking at freedom of movement. The top half is reporting from the wife. The bottom half is reporting from the husband. The bar graphs are sort of, baseline 1 month, 3 months, and 6 months for different ways we measure freedom of movement. All the way on the left is essentially the question is, can you go to these places on your own, right? So do you have the freedom to visit a friend, go to the local health center, go to the community center, a community fair, or a neighboring village on your own? When it started out, about a third, almost to, of both women and men were saying, no, we're not allowed to do any of these things on our own. And as time went along, the numbers, approached like 90 to 80%. And again, going back to this idea of behavioral activation. How can you go out and do things in the world if you're not allowed to, go out on your own? And then we also know sort of isolation and violence have these sort of bi-directional relationship, right? So women who experience violence are more likely to be isolated, and the more isolated you are, the risk of experiencing violence goes up as well. So we're happy to see that the freedom of movement progressively improved. And what was nice about this is that we could also correlate, like, if the wife and husband are saying different things or the mother-in-law is saying different things. And it was also about specific behaviors rather than attitudes. Because a lot of men will sort of have learned to say, oh yeah, I think men and women should be treated equally. But that's just a slogan, right? So like, does that change behaviors? And this is picking up like actual behaviors. No, she is able to go somewhere on her own. That's an actual behavior. So I like this indicator for that reason. And this is probably driving a lot of the both violence and depression. So there's some quotes. I'm not going to read all of them, but I'll just highlight some of them, right? So mother-in-law, we have this, one of the interventions is we show them a story that's very generic. And then after they read the story together, mother-in-law and daughter-in-law, we ask them, hey, what's your reaction? And both of them say, that's my story. And it's a story of a person who's experiencing violence, right? So a lot of the times the mother-in-laws have also experienced a lot of violence. And one way to take that is to say, well, I had to go through it, so you have to go through it too, because like that's all I know. The other way to take that is, hey, like I had to go through it and that was wrong. Like, why would I want her to also go through it? And that kind of allyship is sort of reflected on sort of early. I was not aware that there were so many similarities between she and I, but I was so fixated on like, I got to manage her, like, she's my daughter-in-law and that's my job as a mother-in-law. Husband, there's a whole bunch of stuff here, but essentially he goes, I used to hit my wife due to work-related frustrations. Ma'am, I love that. It's just the husband sort of, because the counselor is a woman, like using respectful terms towards a woman, which is quite rare. So ma'am taught us body scan, very simple technique. And that's the first thing I do now. I come home when I'm stressed out, I just do a body scan. And after doing that, I realize I'm no longer angry. And again, it's trying to show just like, what are these points where you can, turn the levers to reduce a very complicated behavior like IPV. And then this is the woman who, this is her violence is like, we're really nervous when we saw this, like even when she had a newborn, like they were violent towards her. But she was saying even the father-in-law, who really was not part of the intervention, is now changed and they're not as abusive and they're much more supportive and helping out at home and so on. Yes, Judy, go ahead.
You've talked about how the mother-in-laws are often replicating what they experienced in the home. And so do you have any data on whether, even though the father-in-law wasn't part of the study, do you have any qualitative or data on whether this seeped into the home more generally in terms of the mother-in-law's experience of IPV?
Yeah, so not for the pilot studies, but in the RCT, we are collecting for each of the members, we're collecting ACEs, so adverse childhood events for everyone, because we want to see like how much of this is being driven by your own experience with violence. We're not doing the whole ACE, we're just focusing on the violence questions. And then for mother-in-law in particular, we are asking about both lifetime and current IPV. So it'll be interesting to see how much of that is being played out in the household at this time, rather than just something you carry from your past. Great question. So this is an image of our meeting after the pilot was done with our partner Odik, who runs a shelter. And the shelter in charge was like, oh, I know, I was noticing that in the 2 sites that we did this study, the referrals to the shelters were going down. And then she sent like outreach workers to see if there was something preventing women from accessing, and they were like, no, like the violence has gone down. It was so heartwarming to hear that. I mean, that's what we want ultimately, like true, reduction in usage of crisis management and shelters, because violence is actually going down, not because people are scared to access it. So what do we have next? So I've been alluding to this many times. So we have 300 families. I'm very thankful to NIMH for funding this, and the program officer who really risked getting fired to like release the notice of award while, as you all know, was happening with the administration. This was the one grant that just got released days before the whole thing came down, and don't ask, don't tell. But like, I think she did something that helped us, and she took risks. I'm really grateful that this is being funded and studied. Um, the other thing that's coming up now is although this kind of mother-in-law family structure covers really almost like 90% of households, there are other households where the mother-in-law may be dead, maybe not as prominent, father-in-law is there. Like, so we're being asked by our partners, like, can we customize it for other family structures? So we've been thinking about that. And then the question of how do you scale this up? And this is a long conversation. And one thing I'll mention is when we first came up with this idea, because this was based on our frustration with treating depression, right? We went back to the hospital where we were doing depression work, and we said, hey, we have this idea, like, can we test it out in the hospital? And as you can imagine, it was all men being like, that's a cool study, but how is this a health problem, right? Well, what's the diagnosis here? And oh yeah, she's got a broken bone, we'll fix that. But she's got depression, okay, we do counseling. But like, what is this preventing violence? Like, how is it is a healthcare problem? And I was frustrated, but at the same time, like, it was a signal for like, where should scale up even be happening? And maybe healthcare system is not the right place for kind of these social interventions to be rolled out because of their incentive structures are very different. The orientation is very different. What's the diagnosis? Someone was like, how are you going to have the mother-in-law coming to the counseling session? What's her diagnosis? So stupid. So we've been doing it with community-based organizations, and maybe that is the pathway to scale this up. Because when you look at sort of government agencies responsible, it's like, who owns this problem, right? So who is at fault when IPV rates go up? It's like no one, and that's a problem, right? So when you look at these ministries, that there's like a Ministry of Women and Children, and so on, and they don't have the infrastructure to deliver interventions. They will, do advocacy work, they will do awareness raising work, they might help with criminalization, but like there's no space for like women to come in and like get services like this. So it's a really tricky question in terms of how it's going to get scaled up. But the way we're thinking about it is just because there's a pathway to scale up doesn't mean we're not going to do it, right? So maybe we have to show that it's possible to roll something like this out. And then we'll start with community-based organizations, and hopefully the government will be involved. Let's see. I got 20 minutes. Okay, so let me rush through this. The protocol for this MILAP RCT is online if people want to review it. As my bonus round, I'll run through a whole bunch of unrelated or quasi-related studies if people are interested in this. I know we're meeting sort of informally later on, so I'll just mention this if people want to talk about something other than that. I'll tell you, in these invited talks, when I talk about all the work I do, all the questions are about MILAP. So I was like, I'm just going to talk about MILAP, but I'll mention these as well. So this study is taking community health workers to deliver motivational interviewing, of course, and stress reduction and behavioral activation, of course, to sort of multi-morbidity populations, right? So you have anxiety, depression, and hypertension and diabetes. And how do you deliver sort of behavioral interventions? So this is the intervention part. It's a hybrid study. So this is the implementation part. What are some community health worker level, interpersonal level, and system level implementation strategies that can increase the likelihood that these community health worker delivered interventions will sustain over time. This was a study that actually was a precursor to the MILAP study, where we're doing collaborative care, adaptation, and implementation in rural sites in Nepal. And we found that a lot of women with depression had treatment-resistant depression, had violence. But the cool thing about this study now is we're working with the WHO to test this in Ghana and the Dominican Republic. And yeah, we'll see how that goes. This R1, this one's by Fogarty. This is focused on HIV. So we're trying to do more sort of social drivers of stigma, of intersectional stigma in particular. So can a digital tool be used to assess social drivers of stigma and then create a list of interventions that is customized to those drivers and deploy in ART centers. And then this one is another R1. This one's funded by NIAAA, alcohol. And this one, it has a lot of overlap, as you can see. So there's no mother-in-law component here, but this is for couples in which the husband has alcohol use disorder and there's violence at home. And it's really impossible to do good behavioral couples therapy when the husband's like abusing alcohol. So we do motivational interviewing. You see a theme here, and to reduce alcohol use, and then bring the husband in for couples therapy. And to your question, Pamela, recruiting men for this study is very, very tough because you've got men who drink and are abusive, and there's no mother-in-law telling them, hey, you should go. This has been harder. But again, the team, this is in India. The team in India is amazing. They've been doing this for um and this is our bigger team. Thanks to sort of the bigger grant, we're able to do more work and bring these services and test them with a larger population. I think that might be my last slide. Thank you. So there's a bunch of questions online as well. How should we do that? You want to take that?
Part of this.
11, but let's hear from people who braved the cold.
I'll stay quiet for that.
I think you got volunteered, so someone's got to ask.
Structure and not having a father involved in the intervention. I'm from India, and a lot of the family structure is the eldest male kind of dictates what happens in the house. And with this intervention, I'm just like curious how that dynamic takes into this intervention.
Yeah, absolutely. That's a great question. And we get asked by our partners all the time, like, why not the father-in-law? And at some point, you got to balance out, right? So you can keep adding more family members. And then one of the upsides is that you can really intervene at like all the key players. One of the downsides is, well, just the logistics and feasibility of being able to bring everyone in and do their interventions, right? And when we thought through all of that, bringing the husband was really tough. Bringing the father-in-law is even harder, right? Because for him, he's like, it's nothing to do with me. Like, what is this, right? So it became really difficult when we were doing sort of like qualitative interviews that just asking, around, and people were like, yeah, father-in-laws are going to dictate for sure at home, but like so the balance of, yes, they're important, but like, will they actually come in and engage? That's where father-in-laws kind of got cut out. But what we're trying to do now is their interventions, like we have like 140 families recruited, and like what we're seeing is quite positive. So we're hoping if the results are indeed positive, what we'll do is, what are some factors from the MILAP intervention that can be customized for other family members, right? Because some of the basic principles are still the same. So you talk to the father-in-law, what do you care about in your household? Get a list of those things, and then see if you can show that violence is actually getting in the way of achieving those goals, right? And that's the same, but like the specific cases will be different. There's one intervention where we listen to like a popular song, and we point out every part where like gender roles are very rigid, and we will not do that with a father-in-law most likely, right? So those details will change, but the basic principles will be the same. But yeah, it's a limitation of the study as it is right now.
So I just want to know, so since we are using the mother-in-law and the husband, so I think because of all the questions and all these things, because they are the one who are doing sort of intimate partner with the husband, right? So how do you convince the mother-in-law or the husband to be the part of the process of the interview? I think that's really hard in this to get them sitting.
Yeah.
Isn't that okay?
Yeah, no,
How acceptable that?
exactly. No, that's a great question, and it's probably going to be different from site to site. I'll tell you what we did and try to share sort of what I think are generalizable lessons, right? So a lot of the other studies we have done, we mean Possible has done on its own. Like it has an infrastructure, does it on its own. But for this one, we definitely needed an organization that has been working in the field of gender-based violence for many years. Just because, I mean, it requires a ton of trust to open up what's called like a private issue, right, to a stranger, right? And it's not as simple as, I got a broken bone, like, can you please fix it? Like that is, yeah, people go to the healthcare, that's just healthcare system, that's common. But talking about violence in front of other people, there's a huge taboo against that, right? So we had to work with community-based organizations that have a long history of navigating that. And who do you send? Like and how do they introduce themselves, right? If they say they're from like the clinic, it's a very different approach from, oh, like I'm your neighbor, right? And oh yeah, I heard noises yesterday. Like, hey, I'm just checking in terms of what's going on. So this kind of deep community-based, reach that's based on 30 years of trust. Now that's what we relied on for referrals. So that's the infrastructure. The messaging, again, you have to get informed consent and it will say it's about violence, right? But if you lead with that, people are not going to engage with you, right? So we led with, we have an intervention to improve family relationships. We have an intervention to help manage emotions. We have an intervention for communication. So all these terms that we knew are more acceptable than let's talk about violence. And again, we had to tweak the language, and every now and then someone would go back and start talking about violence, and we had to retrain them. So it required a lot of finessing the actual language that is most acceptable. And we have a community advisory board that gives us feedback on you say this, no one's going to come. You should say this, and then so there's a lot of very community embedded approaches that I think have helped.
Follow-up. Did you do as part of pilot or follow the study 1, study 2, maybe any qualitative sort of thing was to explore the acceptability with regard to mother-in-law and the husband while doing sort of this thing? Because the area you are talking about, the moral, because I grew up from the same area, so I'm more context.
Yeah. Most of the questions are around acceptability, feasibility. I mean, one of the best indicators, again, go with behaviors rather than what people say. Like they came to these interventions and almost everyone completed. The only time they can complete is someone's sick in a hospital or they left the country or something like that. So that is the biggest proof that yes, they're engaged and they're feasible, that it's feasible. But yeah, again, going back to scale up, how do you scale this up? If you took the same tradition of let's go find a counselor from the clinic and expect, people to reveal what's happening at home, it's probably not going to work. But if you have a community-based organization that has a long history of trust in the community, it's more likely to work.
You should say something else. What online?
Oh, you want to do online? Okay. Should I?
Here, I can ask you the question.
There's 15.
Letitia, do you want to go first since you're willing and brave?
Yeah, just kind of building on what you just
hear?
said
Yes.
about.
Sorry, we can't hear you
Hold on.
yet.
Okay, now.
Can you hear me okay now?
Yes.
Okay, so building on what you just said about the trusted community, and I'm making an assumption here. This is kind of a cultural thing. The IPV was kind of a cultural thing that was percolating in the background. And I'm wondering in those motivated interviews if you found that these participants identified that this was a cultural issue that had to be addressed and had to be corrected. As far as scaling up, is that, I mean, because basically what you're addressing the cultural issues, not just the family issues, right? Is that an inaccurate assumption of mine?
Yeah, no, I think that's the assumption is correct. I think culture plays a big role in this. Cultural norms around gender, women's roles, the husband's role, even the mother-in-law's role. There's a huge sort of cultural component to it. We've tried our best to focus on modifiable risk factors that are most likely to be acceptable. And here's what I mean by that. So instead of asking, questions like, do you think men and women should be treated equally? Or asking, do you think our culture should be changed? Those are massive things, right? And that work needs to be done. Don't get me wrong. We need to have the community level, societal level interventions, right? But what I found is using these sort of counseling techniques, I am much more likely to be successful to get a husband to say, you know what, my wife is actually, I'm giving her a hard time. I shouldn't be that hard on her. It's easier for me to get him to say that than to say, oh yeah, the way our culture treats women is terrible, right? So it's just such a harder thing to in terms of cultural script to get that to come out of the person's mouth, right? So, and again, I'm aiming low, and maybe that's a critique, and that's fine. But for me, whatever reduces violence, I'm happy with it, right? And if that's what it takes, then you should sort of, instead of making it about your attitude of gender or your ideas about human rights, again, work needs to be done. Don't get me wrong. But like, it's much easier for me to say, for the mother-in-law to say, oh, wow, like when we had that session and she cried and like I put my hand on her knee and like we bonded there, like that individual or interpersonal bond, that is easier to achieve than this kind of cultural awakening, which again, people are working on it. I'm glad they are, but that is harder in sort of intervention like this.
Do you think that's why the 6 month, after 6 months of it raised?
Yeah, so it's unclear, right? So the qualitative data shows that the violence actually went down. The behaviors went down. The quantitative reporting has gone up. And again, our understanding, well, we put all that together, we presented to the CAB members, we presented to the community-based partners, and they're all like, yeah, that's what we're hearing. So it's not just like wishful thinking, right? So what our understanding is that the way women are seeing these behaviors is changing. And maybe that is actually the seed of this kind of cultural change that you're alluding to. That because we've also heard of like spillover effects. Like we've had, qualitatively, we've heard like a mother-in-law will tell like another neighbor, like, hey, you shouldn't be that harsh on, like, and that's like the cultural change, like as like a spillover effect. But again, yeah, it's nice to hear, but that is not what the intervention is really designed for. But again, we'll take it when that happens.
Think
Should we go back to in the room now?
Yeah, let's go back to in the room and then we'll come back to online folks.
Yes, about that, internationally.
Hang on, let me question. Oh, okay, got it. Yeah.
During the interventions, there were chances of escalating, like the intimate partner violence getting escalated. I'm just curious to know what interventions were taken in case if the team members got into that process. One thing, and I'm curious in the sense, like, since I work here for the Alcohol Dependence Project with the National Student Bank here, this is true about, like, we see monkey see and monkey do. So the thing in the country where I come from, it's more like this is pretty normal. We think like this is what my mother had been through, so they don't complain. And even what children see is what they do. So what's your opinion or the idea about that in terms of awareness and conducting?
Yeah, no, thank you. And so I've been asked to repeat the question for the recording, I think. So the first question was about safety, what kind of safety procedures we had. And the second is around sort of, people imitating behaviors or normalizing certain behaviors and even affecting the second generation, which we actually hadn't gotten to in this one. So the safety procedures were pretty standard. I mean, it's what you would expect. Anytime we see escalation of violence, we say, hey, here are a bunch of services. Here's a shelter. Here's a lawyer who can help you. If you want to separate, here's an organization that has like income generating activities. I mean, there is actually almost no shortage of different services, right? But the societal stigma and the pressure and the fear. Again, I understand it. It's hard to like leave what's familiar, even though it may be uncomfortable from the outside looking at it. So we had all these, safety procedures. And then similarly for suicidality, because again, a lot of the women had depression. So, we had a screener that we've used in many of our studies. And if there is reported suicidality, immediately connect them to a crisis counselor on the phone. And if they're still concerned, like, escort them to the hospital for full assessment. So all of those were there. And I'm glad, because we actually got one of our community members are like, why are you doing an RCT? Like, let's just scale it up. And first I was like, well, we don't know because there's no control arm. Like, are people feeling better just because we have a nice counselor talking to them? And there's like this generic effect of, someone is caring about you, right? And that's important to figure that out because you don't need this expensive, complicated thing if it's just meet with a nice person, right? So, but the other benefit of doing RCT is that you can have these very hands-on, safety protocols. That's really hard to pay for if you're doing it sort of on like a ragtag budget, that barely covers the counselor's salary. So we have that. So that's a safety. The other question around sort of, it's related to, I think, the question about culture, right? So it's normalized. And how do you change behaviors in something that is so deeply embedded in your neighborhood, in your household? And I think, again, behavior change is really hard. We didn't see zero, right? The violence is still there. right? And it would be nice if it was zero, yeah, but then these complicated behaviors are very difficult. And the idea of harm reduction, right? So if you're not familiar with it, the idea is you see someone engaging in a behavior that causes harm to their health, and instead of saying, well, you should stop doing it, you say, can we change the behavior in a way that the harm is reduced, right? And this is sort of what we're aiming at. And the goal would be to say, well, there are actually other ways of doing it. And instead of taking a moral, I should say purely moral, instead of taking a strictly moral and rights-based approach, we say, we actually think there may be skills you can learn that will help you de-escalate, right? Which is different from you should not be doing it, which is a moral argument. And we know this from behavior change that moral arguments are unlikely to result in behavior change. But a skills-based approach of like, where are the deficits? What's your motivation? Can we help you get there? We'll see you without judgment. And we'll see you as someone who actually wants to get better. And our job is to help you change. That is more likely to lead to sustained behavior change. And it is tough. And one thing I'll add is OLEC, the community-based organization, comes from a very strong, feminist background of approaching violence against women. And we had some very difficult conversations about this because there were so much like, how can you work with a perpetrator? Like, and in the middle of the counseling, their counselors would start saying like the perpetrator, and you gotta, and we're like, can we be non-judgmental? Like the woman's telling us she can't leave. It doesn't help us to keep saying perpetrator. And then he'll say, we're not going to go to counseling anymore. And that's the end of that. Like, it may feel morally righteous that we said that, but like it actually worsens violence, right? So it's a very difficult sort of balance, and I don't want to again minimize any of this, but using evidence-based techniques for behavior change at an interpersonal, individual, and family level is my hope of like changing the behaviors that have this huge cultural overlay sort of working against it, and we'll see how it goes. I'll look at her. I don't know if it's the online turn, your turn.
Let's go with you and then we'll go on.
Thanks. Average amount of time that these women have been married before they come into this?
Yeah, so for the first study, we actually limited it to you had to be married in the last year. So these were newly married women. Because my worry was, if you've been married for like 5-10 years and there's been violence, like what can like a counseling session do? Like there's just so little. Again, it's like I was just trying to aim at something that can actually be modified. But then again, we heard from others saying, no, like these techniques might work. Let's expand it. So in the second study, there was a bigger, I don't have the numbers with me, but we didn't have any limits like that. So we had people who were like in their 30s and been married for like 15 years and so on.
Awesome. Asta, we're gonna go to you online.
Hi, Bibhav.
Hi, Asta.
Hi, everyone. So, Bibhav, thank you. Firstly, thank you very much for this. I think I have a few questions. I think when I think about violence, and we're thinking specifically about intimate partner violence, but what I am interested in is whether through this study, if you have recognized other types of what are the different types of intimate partner violence that you are measuring, and does that change based on like the place that it's happening, the situation within which it is happening, and is there anything modifiable or preventable over there? So that was my first question. And then the second question that I wanted to ask about was whether if you've heard any information from like the mother-in-law or the husband where the woman speaks back and it's taken from their perspective, it's taken as a form of verbal abuse. And so it has led to physical violence maybe, but then the mother-in-law and the husband also think that this is a form of partner, like a form of violence towards them, So just because I feel like when we talk about violence, especially within the household, there are so many different situations and different forms. And I think trying to understand all of that and then think about which specific one you want to prevent would be super helpful. Thank you.
Yeah, thank you, Asta, for all those questions. And this brings to the theme that sort of Judy had started, right? So who provides care, right? So it really comes to the counselor at first, right? So we can train the counselor in this sort of manualized, say this, do this, or we can say, here are the principles we want you to use, right? So that depending on whichever type of violence is the most common and whichever sort of situation is driving that violence, you can, you can modify the approach to help that person. So I'll give you an example. So one of the most common times violence happens, this is something we have the counselors ask, right? So when does violence happen? Sounds like I'm describing a child, but like the husband comes back from work, is hungry. Yeah, and they're like, that's when violence is most likely to happen. So one of the interventions is you come in, you eat. Like I kid you not, like you like that's what I do with my kids, right? It's like you eat, and then you don't even interact, right? The woman's not the one who welcomes him at home, right? So he just goes and he eats, and then does a body scan if we train him to do that. And then the rates of violence go down. Like it's just something that is very like practical and situational, like you said, right? But again, not everything is that simple, right? And studies have shown this. Like you have your favorite team loses, and like rates of violence go up, right? This is a very complicated thing in terms of how the different drivers ultimately lead to violence. So the counselor needs to be sort of equipped to have that flexibility. So that they can use the principles for different types of violence, and then this sort of the question of which kind of violence is more common, and how is this level of detail. I love, of course, you'd ask this, but like we were hearing from counselors who'd say things like. The counselor would try to say, okay, you're a couple, you got to work together, and they would try to focus on the relationship. And the husband's takeaway was, oh yeah, so she has to do all the household chores, right? So he would sort of like take it in like well, yeah, this is consistent with what I've been saying all along, right? So the counselor had to step in and say, no, like what we're saying is like you're a couple, you got to work together, meaning like you got to take some of the tasks as well, especially when she's been doing X, Y, and Z all day. This kind of like, again, not in a confrontational kind of moral way, but like a practical way. Like, so, things are less likely to get done if it's the same person doing everything versus you helping out, right? And the mother-in-laws oftentimes would say, okay, yeah, I'm happy to help out with these things. And they would like list the chores and say, I can help you with that. And, that's yours. The question that you're raising around, like, when women become more assertive after engaging in, interventions like these, does that backfire? Is exactly one of the risks of, couples intervention or family intervention, potentially increasing risk of violence. And again, this is nothing new. Like I did couples therapy in my training, and we're trained to do this, right? So anytime there's a fight that happens outside of the session, one of the first things you do is, have there been any fights since the last time we met? They say yes. You actually revisit that and you say, what did you say? What did you say? What happened? And you get to essentially replay that with a counselor who can then say, oh, let's actually let her talk. That kind of, facilitation that doesn't exist in the household. So that's how we've been doing it. But it is tricky because, you need high quality counselors. And to expand the question of who provides care even further, in some of those things are now actually being implemented by the mother-in-law. So the mother-in-law at home, she's saying, hey, like when the husband's like getting louder, remember that body scan technique that you learned? Like this is the time for you to go do that. Like, oh no, you guys go to like different rooms. Like, this kind of intervention that in the past the mother-in-law probably was like, this is normal, right? So, what am I going to do about it?
All right, I'm going to take one more from online and then we'll come back in the room because I know there's some chat folks that are waiting. Can you please elaborate on the qualifications of counselors and how intensively you train them?
Yeah, thank you. Was that Yoko?
Yes.
Thank you, Yoko. The counselors, again, in different countries, they're different. We train what are called psychosocial counselors in Nepal. They often receive like a basic 3 to 6 month training on basic helping skills. They don't learn motivational interviewing. They may have learned how to use like PHQ-9 and things like those. They may have learned like deep breathing and just like a very fundamental low intensity interventions. And the training, again, we're lucky to have an RCT that provides the infrastructure to provide really good training. The manual was refined multiple times, and fidelity scores and mock interviews and so on. And yeah, so once they reach a certain threshold, we say they're ready to go and see patients. But yeah, so that's the sort of summary of training.
Can I ask a follow-up question on that, if that's okay?
It's her call.
Yeah.
Thank you. No, I think my question was about the educational background of the counselors. Are they finishing the high school or something beyond that?
Yes, high school graduates. Yeah, high school graduates who have completed 3 to 6 months sort of psychosocial counselor training.
Thank you.
Thank you.
Take one more.
All right, yeah, I was gonna take one more, so can I actually have him go? And then we'll close out the questions part, and then I know folks in the room will have some time still, so.
I got nowhere to go, so you can find me later.
Please. What your goals are, what you failed, if you understand or if you failed. I'm just trying to think what I can chance me or you have goals that when quest that we have like the goals do not marriage. So
Yeah, so the questions around like the policies and how do they regard IPV, right? So it's different in different countries, and see what's happening in America. Like it is these rights need to be fought for constantly, right? Because it's just so vulnerable to being eroded. In Nepal, it's illegal, even on paper, right? So even if it's like a married couple, if there's violence, he could actually go to jail. So that exists, and it should exist. But there's multiple problems with that. One is how is it being enforced, right? So that's the first. And the second is, what is the consequence of a harsh punishment? And it's a double-edged sword. Like the punishment is really, really harsh, the likelihood of reporting actually goes down, right? It's the same thing. Like, if you say something and the husband's like locked up for like 10 years, the consequence for the woman is like worse, right? From the family and the society. So and all these complex systems issues, like you got to pay attention when you turn something, what are the unintended consequences. So again, these need to exist, and at the very least, they convey that this is wrong, and I think that needs to keep happening. But we can't just rely on sort of law and order aspect to reduce violence, because we know it's obviously not working.
Awesome. Thank you. Thank you all so much. Online folks, thank you for participating. We're going to stop us there, and I'm going to turn it over to Pamela to close us out.
Of course. Thank you so much, Bibhav.
Thank you. Thank you.
Wonderful. Let's get a round of applause.
Thank you.
Yeah, and I appreciate this was a really, I think there's probably going to be a lot of continued discussion in the room for a little bit, because this was a really wonderful example of how do we provide care, who provides care, and when care isn't working the way we expect, how do we get to the social issues that are driving it? And I love this example of going to the family, right? Looking socioecologically and then saying, what are we missing, right? What are we missing in that set of potential responses? So thank you. So we hope that all of you will make sure you're on the mailing list and continue to follow along our speaker series, because we'll have a bunch of cool people coming in the winter as well. And Bibhav, we hope to have you again. So we look forward to it. So thank you so much. Have a good evening, everyone.
Thank you.